Good evening, everybody. Let me start with thanking for giving me this podium and for the chairperson for the wonderful introduction. See, antipsychotics are a double-edged sword. We need it because it has pushed people who are purely institutionalized into the common society. But there's a hidden cost. There's a lot of metabolic cost that is involved, and there is diabetic which is increasing secondary to these drugs. The antipsychotic medicines are so important because in causation of diabetes, patients with severe mental illnesses clearly have a 15 to 20 years earlier mortality. There's a 60% excess mortality either due to cardiovascular diseases or due to diabetes caused secondary due to the medication itself. And not only that, people who use it as SOS, let us say somebody has got somebody who's got a depression or this thing who uses SOS medication, compared to them patients who use regularly the drugs, they got a double the higher risk of having mortality. So we need to find ways of, the question is how do we treat their mental illness without destroying their body, which is very important. But when you talk about the causal association, there is a difficulty in documenting this causal association for three reasons. Number one is that the metabolic abnormalities. Many of these patients have binge eating and other problems. Many of them become a diabetic or they are pre-diabetic even before they get these diseases, number one. Number two, obviously there's a screening bias. When they have a mental illness, we are going to, looking at different things. So the RCTs are less common in this particular thing. But the link between antipsychotics and diabetics may be an association rather than direct causation has been a question. But this has been laid to rest. In 2019, there was a large meta-analysis which looked at review of multiple papers, which clearly showed that in epidemiological studies, there is association between the antipsychotics and the initiation or prevalence of diabetes, number one. In 2024, in a clinical study which contained around 4 lakh patients, where they clearly confirmed that antipsychotics are a cause for increase in the diabetic thing. The scale of the problem is so high, there is a 2 to 4 times fold or 2 to 4% or times of increase in diabetes in these patients, number one. In the antipsychotic usage population, there's a 10% prevalence of diabetes. And not only that, diabetes is found to be earlier on its onset compared to the normal population. And it is more with the second generation antipsychotics compared to the first generation antipsychotics. The first generation antipsychotics had around 1.7 times higher versus 4.7 times higher for the second generation antipsychotics. These are all second generation antipsychotics. The first generation antipsychotics, we came into the second generation because the extrapyramidal symptoms were higher in them. So utility of them and the side effect range was more of the extrapyramidal symptoms. Whereas in the second generation antipsychotics, these are the main list of second generation antipsychotics. If you can look at it, the thing, the cognitive symptoms improvement was better with clozapine, olanzapine and QTPN. But unfortunately, the weight gain, type 2 diabetes as well as dyslipidemia also increased. Whereas the lesser amount of side effects in terms of Parkinson's symptoms and extrapyramidal side effects was there. So it is necessary that we need to transition into the second generation of antipsychotics. At what cost would be the question. So possibly one thing which we can use is that in patients who would need multiple antipsychotics for control of symptoms, you need to use this thing. They are in the highest risk quartiles. They need to be identified, and we'll come to that. In patients who got lesser amount of disease, if possible, you should step down the therapy to possibly aripiprazole or other thing like the amisulpride, where you'll have lesser amount of diabetes conversion in such patients. How does this happen? What is the mechanism? Mechanism is very clear. There are 3 things. One, as I told you, many of them, these people have binge eating, they have difficulty in difficulty in controlling them. It's all there. So weight gain is a possibility, but it's not directly weight gain. Insulin resistance is not the thing alone. The drugs themselves cause change in the receptor antagonism of the 5-hydroxytryptamine receptor 2C or the H1 receptor. This antagonism drives the appetite and the metabolic disruption in such patients, and they have higher amount of leptin. These two things directly affect the number of people who convert into frank diabetics in reality. Obviously, once they have a higher amount of appetite and the thing, they become insulin resistant, they put on weight, and this drives the beta cell failure, and possibly they have more amount of diabetes. And we already talked about the weight gain in such drugs. We talked about the insulin resistance, but in the schizophrenic, basically, at least in the spectrum of diseases with schizophrenia, this itself causes, there are epigenetic as well as endogenous metabolic changes which occur, thereby these people put on weight and they land in diabetes. As far as the weight gain is concerned, it is not linear. It is more within the first 3 months, but they continue to put on weight even over a year's time. So you need to identify the drugs if possible, change them if possible. So there is risk, which is this thing. Scoring, you look at the first 3 months and then the thing will come to that. And not only that, dyslipidemia is a problem. Clearly, documentation has been done to say that this is visceral fat which increases and not just purely the pure weight gain, which is the thing. They have documented that it's a visceral fat which increases in these people. Coming directly again the thing, to the drugs, it causes the higher affinity to the M3 muscarinic and H1 histamine receptors. So thereby weight gain increases. The drugs which causes lesser amount of the thing has got less effect on the thing. There are studies to show that antipsychotics alter the gut microbiota. Thereby, and those drugs which cause higher weight gain, higher the thing, affects the gut microbiota more. So there is a clear relation to this thing. So what can be done is that to mitigate this risk, lifestyle should be this thing, but many of them may not listen to us is a problem. Possibly if there is a weight gain, even if they don't have diabetes, people have started using, there are things to say that metformin or to prevent weight gain drugs have been used. In patients it is possible to step down therapy, drugs which are less prone to cause diabetes can be tried on such people. In 2004, there was a consensus statement which said that any patient who are put on this second generation antipsychotics need to be screened at baseline with a BMI, weight, BP, HbA1c and lipids. Again, you screen them at the 3rd month, that is the 12th week, to know if they are gaining weight. If so, then you need to start intervening. They can continue, as I told you, they can continue to gain weight even up to 1 year. When you should keep, in such patients, you need to keep assessing if the same amount of antipsychotic needs to be used. So, as far as management of diabetes goes in such patients, number one, you cannot stop the drug because like both schizophrenia and the thing that their lifestyle is literally spoiled. They are in disarray. So, you cannot simply this thing. Possibly a step down is possible. Where it is not possible, you can start drugs like metformin early. If there's a 5% weight gain in the 12th week when you do a screening, in such patients possibly a preventive drug has been an acceptable thing. There have also been studies where they have taken away the drug and they have shown that they revert to the thing. So why this is important, that if you recognize that there's a weight gain and a possibility of hyperglycemia in such patients, you can either step down the therapy, number one, or you can give her this thing, when they become better, you can give a drug holiday, so that there's a reversal and you can start better lifestyle intrusion to contain the weight gain and other things. But we need to remember that there is going to be poor compliance, because it is very difficult, because they live in the world of their own. So it is very difficult for us to initiate such lifestyle changes for such patients, because they are already suffering a lot. Not only the substance abuse, including smoking, is very high, thereby the accelerated complications of diabetes and weight gain occurs in such patients. Not only that, elderly patients who get such these things, they are in a set pattern where your lifestyle changes are going to be very, very difficult to think. So what needs to be done is, as I told you, one is screening. Second is lifestyle guidance to the people around them, so that you are able to impart that these people may gain weight. You have to look for it. I have a few children who are who are schizophrenic, who have, but the main thing is they are unable to stop eating. With GLP-1s, we are able to offer them this thing, but the nausea, vomiting, they are unable to accept compared to a normal patient. So it's a very tricky situation in using these drugs in such patients. So coming to the therapy, metformin is the first line. As I told you, even if there's a 5% increase, you can start using metformin. SGLT2s have been shown to be useful, but it's a double-edged sword. A lot of people have more infection, more the thing. Euglycemic decay is more, you may not recognize, they may not come with the complaints very early on, so it may be a possibility. GLP-1 analogs seem to be one of the best answers that we got today, but we need more amount of the thing on it. As I already alluded to, switching the antipsychotics, withdrawal or step down of the dosage, and regular monitoring would be the key. In conclusion, the benefit and balancing the risk of using such drugs needs to be monitored, number one. So it should be a key thing between you and the psychiatrist, so that you have the thing, educate the stakeholders. The entire family should be involved to possibly give them a better outcome. So refer to weight clinics when necessary, so that possibly they can do something more to them for this thing. And a regular monitoring, as I told you, a score of at the baseline 12th week as well as at the year end is very much necessary. Thank you for the opportunity given. More needs to be done for such patients. Thank you.
Thanks.